We're turning now to hope and optimism for BPD in Australia, and it's my pleasure to introduce Adjunct Associate Clinical Professor Sathya Rao from Monash Uni. He's also Executive Clinical Director of Spectrum, the Personality Disorder Service for Victoria, Deputy President of the Australian Borderline Personality Disorder Foundation, and a member also of the NH&MRC BPD Guidelines Development Committee that delivered guidelines in 2012. His images are still coming, so I'll slightly slow down in that ABC kind of way. Ah, yes, here we are. He is indeed a psychiatrist and a psychotherapist, and he's written extensively on BPD. Would you please welcome Sathya?
So I'm the psychiatrist. Okay, thank you, Julie, for that warm introduction. And Mali, I'm still preoccupied with what you said, and your speech was truly inspiring, and it really keeps us going. Thank you very much for that. Thank you, thank you.
Amalia's just saying Spectrum saved her life.
I'm sure that was before Bryn Grainer.
Yes.
Okay, let me get started by paying respects to the traditional owners of the land. Hope you've been enjoying the conference so far. I've been really enjoying it, and I'm delighted to be talking on this topic, as I truly believe that there is indeed hope and optimism for BPD in Australia. See if I can operate this. Yep. Now, I want you to imagine for a moment an ideal health system and in a country. Let's say a country the size, population about 17 million, little less than us. What would that look like? Every person with BPD would be able to access evidence-based psychological treatments by traveling not more than an hour from their homes. That would be ideal, and it should be free of cost. And treatment should be able to be accessed from specialized BPD centers where possible. And people should be treated for at least about 18 to 24 months. I take Bryn's point that still the science is grappling with it. But the current evidence says that at least you need to be working in the long term. It should be both individual and group treatments. And families also get help every week for 18 to 24 months, believe it or not. Early detection and early intervention should be available. And the therapists, I'm talking about psychotherapists, should be able to make home visits and school visits and have outreach services where patients and families are not able to come to the center. And there should be specialized crisis management services for BPD so that we can save lives. And there should be programs for parents and school teachers and prevention, the kind of work Bryn is hoping to start. There should be early treatment programs starting from the age of 12, because in NHMRC guidelines we can now start making a diagnosis from the age of 12. And there should be treatment programs for the adult population, 18 to 64, and also services for the old age. We're now beginning to see people with BPD who are 65 years and older. And mothers and people with pregnant women with BPD should be able to access services. Now, at-risk children as young as 5 years old should be able to get help. Of course, we're talking about helping the family unit as a whole. Looking at primary prevention. And patients should be welcomed with open arms in services. And the only exclusion criteria in that particular country is acute schizophrenia when they're acutely unwell, or severe intellectual disability because it may be a challenge to do psychological treatments, and when there is no home address. I don't agree with that particular criteria. And the attitude is, it's never a hard no for inclusion. So the idea is to include everybody. 20% of all BPD patients are treated with high quality evidence-based treatments. Waiting time is either 0 to a maximum of 6 months. And while they are waiting for treatment, evidence-based treatment, they get some sort of help. They're not just left alone. Say about 15% dropout rate. 80% of patients achieve symptomatic recovery. This is not surprising because this is the kind of data we are looking at. And in one of the centers, 3 suicides in 10 years. More than 4,000 clinicians are trained in that particular country, enough to treat 50% of all patients in 8 years' time. High quality supervision and training is accessible. Patients get help with employment and schooling. And if BPD patients are in crisis, the GPs are told not to admit them in the first instance to psychiatry hospitals, but the specialized clinicians would make home visits and actually do crisis intervention to prevent an admission and prevent any suicidality. So no wonder the completed suicide is so less. If admitted, there is early discharge, follow-up treatment in the community is offered. They're not just left alone, because if you just discharge them out of the hospital without any treatment, that's where there's a higher risk. BPD patients or their families, if they come in contact with the child protection services or criminal justice systems, they're not taken to courts and put in prisons, or the children taken away from the parents, but treatment is offered, therapy is offered. No wonder in that particular country, they're actually closing down the prisons because they can't fill people in the prisons. I'm sure some of you are guessing which country it is already. 5% of the budget is spent on quality assurance. They're not just doing evidence-based treatment, they're also making sure that it is evidence-based, the quality is assured. They spend 5% of the budget to ensure the quality. More than $2 million is spent on research and development. About $50 million budget for personality disorder specialist centers. And there are 4 academic professors for BPD alone. So if people with BPD have co-occurring disorders such as substance use disorders, eating disorders, PTSD, right now we don't have treatments. In fact, I was just talking to some of the parents here. They were talking about how we keep sending patients from eating disorder clinic to BPD services to eating disorder clinics or substance use disorders. You're told that you stop giving up drugs, stop using drugs, and then come to us, the BPD services. The BPD services would say that, and the drug and alcohol services they use, you fix your BPD and then come back to us. We need to really start working together. So in this particular country I'm talking about, they actually solve the problem. They work together. And if there's domestic violence, women and children are supported with therapy. The attitude the clinicians they have is that if it has to be done, it will be done. That's the kind of attitude. Of course, it's Netherlands, and that is where this happens. I had the pleasure of visiting Netherlands just a few weeks ago and visited their services quite extensively. So this is what is happening in Netherlands right now. And as I said earlier on, they have a population of 17 million. We are about 24 million, not too much of a difference. And they seem to have solved a lot of problems. And they are far, far ahead of us. We have a lot to learn from them. And they have demonstrated that it is actually possible to do all these things. It is not, you don't need to really imagine, we don't need to be struggling. They have actually demonstrated it's possible. Of course, and the size of the Netherlands is about 186 times smaller than Australia. That's going to be a problem, but we can do it. I believe we can do this in Australia too. We certainly can do it. Now, what are the current challenges in Australia to achieve a healthcare system which is similar to Netherlands? So as we have heard, the prevalence rate is about 1 to 4%. So the estimated 1% of the community, which is 240,000 Australians with severe BPD manifesting suicidality and self-harm, need urgent care. So just to do a quick recap, we know that BPD is a highly stigmatized disorder, highly misunderstood, but we know that it is a reliable and valid diagnosis. Unfortunately, we still lose 10% of people for suicide, and 85% of them self-injure. They have significant medical illnesses. Their lifespan is reduced, and medication, unfortunately, we still don't have a medication which is patented for BPD. Psychological treatments are the only treatments, and they do work, they're evidence-based, and prognosis is good with treatment. Fortunately, remission is common. Recovery is definitely possible. I wouldn't have believed this if I had not seen people recover and go into remission myself in my work. And if any of you clinicians, anybody don't believe it, ask them to come to Spectrum, come and talk to our patients. How are we responding to people with BPD right now? BPD is often underdiagnosed. Early diagnosis in children under the age of 18 is very uncommon. Early intervention is rare. The irony is that the early intervention was actually pioneered in Australia, in Melbourne, by Professor Andrew Channon. Now, most people with BPD don't get any evidence-based treatments in Australia. Our mental health workforce is poorly trained in the management and treatment of BPD using specific psychological treatments. Our mental services are not ideally set up for managing BPD. They are actually set up for managing schizophrenia and bipolar disorders. So there is significant discrimination, as we have heard today, and we still don't see BPD as a legitimate mental illness. They are frequently excluded when patients attempt to access services in mental health services and emergency departments. And if they are lucky to get into the service, often the service what they get is substandard and inadequate. So, in summary, we actually have a very chaotic and fragmented approach. We don't have a population-based approach for BPD. We know that the usual treatment, which is the treatment as usual, does not work, which is admission, discharge, medicines, and crisis work, but that's what is commonly offered. So what do? We medicate patients, we admit them to hospitals when they're highly suicidal, and we discharge them without any follow-up with evidence-based treatments. See, unfortunately, the mental health services are also struggling with inadequate resources, and it is people with the diagnosis of BPD who are most heavily impacted by this. So there are major gaps in service provision throughout the country. Some states may do a little better, like Victoria and now New South Wales. And there is significant burden on health resources with the diagnosis of BPD without providing evidence-based treatment for BPD. In fact, if with the current amount of money we are spending for borderline personality disorder, without providing the right treatment, which is with ambulance, police, medications, inpatient admissions, emergency department, that amount of money would be more than enough to provide evidence-based treatments. We clearly know that treatment is cheaper than no treatment. However, not all is doom and gloom. On an optimistic note, we have made lots of progress in Australia. We have considerable interest in borderline personality disorder now. When I started my career in borderline personality disorder, I was told that there's something wrong with me, and are you doing a career suicide? So here we are today. So we have the National BPD Foundation, led by Julian McDonald, who is here with us today. Julian, you really inspire us. Thank you. And we have Jan McMahon in Australia, who is a beacon of hope for borderline personality disorder. She's a very passionate advocate for BPD, and she's the patron of our BPD Foundation. Thank you, Jan, for all that you do. As we heard in October, as we heard that first week of October has been declared as the BPD Awareness Week, and Guy Ellis and Anne Reeves have put together a brilliant website. I would again remind you and ask you to, request you to look at the website. And we have held the 6th National BPD Conference in 3 different states, which is again significant progress. We heard about the national guidelines. We had the National Expert Reference Group. And we actually have a world-class Center of Excellence for Youth BPD Service in Victoria, led by Andrew Channel. So we have made some progress. The Project AIR initiative, led by Professor Bringrainer, who set up an excellent service in New South Wales. I would highly recommend Brin's website. In fact, I use that website whenever I'm working with patients. That website is world class. So if you're looking for information, please go to Brin's website. And we have the National Education Alliance, which is starting to do a lot of work. And Spectrum, the service which I lead in Victoria, has been around for now 19 years. We provide some sort of care for at least 500 patients every year. We train on an average 1,000 clinicians, so we have trained about 15,000 clinicians so far. And the FRANZCP guide, which we're talking about. So these are the list of progress we have made so far. Now, what can we do to end stigma and discrimination and replace it with hope and optimism? We need to continue to raise the awareness. We need to continue to have this sort of conferences. We need to really continue to educate the community. We need to have a large media campaign. So every single Australian should know about BPD, like they did for depression. So even if you go to the loo, you'll see the Beyond Blue stickers. So we have to implement the NHMRC guidelines urgently. We really don't have an excuse for it. We have to lobby with the government to declare BPD as a public health priority in Australia. We need to develop a population health approach to care of BPD, which would then translate to treatment for every single patient. And we need to establish a national training framework for BPD. We need to actually train everybody. We need to start training psychiatrists, GPs, medical students, psychologists, social workers, and health workforce broadly. I used to be the previous chair of the training program for psychiatrists in Victoria. I know intimately that we don't train psychiatrists enough in treatment of borderline personality disorder. And Bryn was very right. Now, we also need to scientifically examine the cost effectiveness of treating borderline personality disorder and demonstrate with really good evidence that treatment is cheaper than no treatment or bad treatment. So for this, we need to commission a national BPD implementation research science. We actually need to start talking the language of the funding bodies. That's what they did in Netherlands. They demonstrated with really good studies, large studies, that it is actually cheaper to treat than not treat. And then they lobbied with the government, they lobbied with all the political parties. That's how they got around. And we need to do this too. We actually don't know what would be the ideal model of care for BPD in mental services. We have been struggling in Victoria for the last 2 decades, and Bryn is trying out in New South Wales. We don't have the clear answer. I don't believe that there's a clear answer in the world. So we need to look at what's going to be the model which is ideal for us in Australia. So that needs research. Yes. So we need a national research center for BPD that can act as a think tank. We also need a national framework for family and carers. We need to create a national registry of all accredited and evidence-based treatment providers for BPD so that family members and clinicians can actually access. Otherwise, we don't know what sort of treatment people are getting. We also need to establish a national suicide registry so we could actually start counting the numbers and look at the burden and the true mortality rate. And we all need to come together and support the Australian BPD Foundation, and all the key stakeholders need to work under a single banner. So even if you count 1% of people with BPD and their family members, relatives, spouses, children, and 1 or 2 clinicians, we got 5% of the Australian population. Imagine if 5% of the people come together. We'll be such a strong political lobby. So we also need to establish specialist centers of clinical excellence for BPD in every single state and territory of Australia. So that's why I believe that spectrum-like services are important to be able to take on that sort of a role. So I'm going to skip a couple of slides because all of you already know about spectrum. I've actually done a bit of a calculation of the funding. If every Australian citizen can spare $1 a year, $1 per year, that'll give us $24 million. That's enough to set up a Project Air-like service, Spectrum-like service in every single state and territory in Australia, and also set up a research center, a think tank. That's, of course, still just the beginning. We need to go beyond establishing Spectrum or Project Air-like services and get it and have a population health approach for BPD. Thank you.